So good morning and welcome to this workshop on the burden of foodborne diseases, the relevance of the methods and relevance of national studies. My name is Sarah Pires, and with my co-chair, Brecht de Vleschauer, I'm hosting this workshop on the name of the European Burden of Disease Network, a cost action. We have 4 speakers today. I don't see my presentation yet, but yes. So we have 4 speakers today, Binyan Desta from the University of Waterloo, Lapo Mogini-Gras from the Institute of Public Health and the Environment in the Netherlands, Tina Held from the National Food Institute in Denmark, and Peter Heuschel from the European Office of the World Health Organization. We'll have a workshop for around 1 hour, and we'll have time for some questions and Q&A in the middle of the presentations and hopefully at the end of the presentations also. But I'll start with a brief background for this workshop. So burden of disease, they still cause a high public health impact worldwide, and this is despite increased political attention. The World Health Organization published in 2015 a report that showed that burden of diseases, that foodborne diseases cause a burden that is equivalent to other relevant diseases worldwide. Showed, for example, that 1 in every 10 people worldwide gets sick, and that foodborne diseases cause up to 33 million healthy life years lost globally. This report also showed that the population, global population, is not equally affected. And as you can see here, there's regions in the world that bear a higher burden, like Africa and Southeast Asia. And that also the relative importance of different groups of foodborne diseases and different diseases varies. So while this report was very important to put foodborne diseases in the agenda, it still faced a number of challenges. So it was the product of a huge initiative that faced, for example, methodological challenges and data gaps. And this is because it was such a global effort. It also lacked the precision needed to identify priorities at the national level. And importantly, it was not able to make use of all the resources and the local knowledge that might be available in different countries. So why do we need national burden of disease studies in foodborne diseases? Well, they will allow us to answer 3 important questions that decision makers will need to have answered to prioritize food safety efforts. What are the most important diseases in a specific population? When we focus on these diseases, what are the most important sources, and then which interventions will be effective in reducing these diseases? Implementing national burden of foodborne disease studies will also obviously allow us to make use of the local knowledge and data that might be available in each country, and then to adapt specific study requirements to the local needs in the local settings. So in this context, we looked at the burden of disease landscape of global burden of foodborne disease studies, of local foodborne disease studies, and we identified that these are still a minority. Studies are still mostly restricted to high-income countries in some parts of the Western world, and many other countries still lack awareness, the resources, and data to estimate burden of foodborne disease, which of course leads to researchers that are trying to implement studies struggling to translating their knowledge into decision policy and information for decision making. So in this context, the aim of this workshop is to demonstrate the need and the utility of national studies for foodborne disease, and to share some of the success stories of the studies that are already out there and discuss opportunities for the future. As I said at the beginning, we're hosting this workshop on behalf of the European Burden of Disease Network, which is a cost action that any of you interested in burden of disease in general can join, and you have the information here. And we tackle all things burden, including foodborne diseases. And with this, I would like to introduce our first speaker, Lapo Mogini-Gras. And Lapo is an epidemiologist and senior scientific advisor at the Institute of Public Health and the Environment in the Netherlands, and also an associate professor at the Institute of Risk Assessment at the University of Utrecht. So Lapo, the floor is yours.
Yes, can you hear me and see? I hope.
Yeah.
So thank you very much for inviting me, for having me. And yeah, indeed, as you said, today I would like to talk a little bit about what is being done, what has been done in the Netherlands for the estimation of the burden of foodborne diseases. So to give you a general overview and how we interpret this data and how they can inform public health indeed. So before doing that, just a little bit of background. Yeah, the Netherlands, like other industrialized country, realized some time ago already that foodborne diseases, despite the hygiene standards, still cause substantial public health and economic impact. So an empirical approach was needed to generate evidence, data-driven evidence to form policy. So to measure the burden and cost of foodborne diseases. And in the Netherlands, it all started with this man here that you may know. It's a pretty well-known person, Ari Abelaar. He's now professor at the University of Florida, but he worked for 36 years, I think, at the RIVM before moving to the US. And yeah, in the Netherlands, where the whole the magic happened, and he was one of the initiator of this line of work. Is now an official mandate of the Ministry of Health that mandates us every year since 2008 to perform these calculations and to publish them in publicly available reports available on our website, and they're written in English as well. It's not for all diseases, but it's for an agreed upon panel of 14 enteric pathogens. The metrics that we used, as expected, are the DALIs for the calculation of the burden of disease, which is a very well-known metric for calculating the burden. It summarized incidence, duration, and severity of symptoms as well, so it's very comprehensive and comparable, also with chronic diseases, for example. And for the cost, we use just euros, so it's in the currency, and includes not only the healthcare cost, but also the cost for the patients and the caregivers, like for example travel and external care, but also productivity losses, for example work time lost because of the disease or because you have to take care of the disease burst. This is the list of the pathogens that we are considering, the 14 pathogen. I don't know if you see the pointer, but maybe you can put the pointer. I know, yeah, now it should be public. And that means that for every disease, we have an outcome tree, an infection tree, where you have usually an acute phase of the infection, and then you might have sequelae, so long-term consequences, and then mortality. And these are the input data together with the disability weights that you need to have for calculating the years of life lived with disability, but also the years of life lost. And not for all pathogens we will consider the same sequelae. Yeah, almost all of them will cause diarrhea, gastroenteritis in the good phase, but then only some of them will cause sequelae, like for example Guillain-Barré syndrome, reactive arthritis, EBD, etc. So, and as soon as this information is available in the literature, so there is enough evidence to say that a specific pathogen causes a specific sequela, this table can be updated, of course. We have to rely on a lot of different disparate sources of data to compile to estimate the burden for all these pathogens. And for some of these pathogens, we have a very established, robust surveillance systems, especially lab surveillance systems for notifiable pathogens like Listeria or STEC. But for others, we rely on Sentinel surveillance system that are reporting to us on a voluntary basis. So we have to account for underassertment, but also underreporting. So to reconstruct the pyramid of the surveillance pyramid, and we used multipliers that have been estimated a long time ago, thanks to different studies that have investigated the incident, but also the reporting and other factors related to that at different stages of the surveillance pyramid. We use data therefore from surveillance system, but also scientific literature, and also official statistics from the Central Bureau of Statistics, especially for the mortality and the life expectancy. So this is how it looks like, the report for all diseases. I forgot to say we have two different reports. One is for all infectious diseases, including foodborne infections, and one, this is this one I'm showing here. It's written in Dutch, but the picture is very intuitive, I think. And the other one on foodborne diseases then is also published apart and is more detailed, with more detailed numbers, and also a part about attribution. You can see here, for example, in this graph that the DALYs per infection and the DALYs overall in the population, and you can see the differences. Some diseases have a high individual burden, like for example tetanus, but it doesn't occur that much. So at the population level, the DALYs is low. But then you have, for example, influenza that has a very high DALY is the first one ranked here at the population level. Then you have Pneumococcus, Legionella. Now I'm scrolling down, but you can see that therefore, then at some point we see Campylobacter, then we see Toxoplasma, Norovirus, Salmonella. So then you can see that the foodborne, or at least the gastrointestinal pathogen, score in the top part of this graph as well. Doesn't scroll down. Yes. Next slide. So, and this is the last estimate I could show you. So the burden of disease for the foodborne disease in 2018 for the Netherlands. I wanted to show you the most recent ones for 2019, but the report has been delayed. Usually in September we publish the report, but because of Corona, it all went bananas. So we had to wait. Probably we have to wait until December. So this is that the estimates for 2018. A total 11,000 DALYs estimated. The Dutch population is about 17 million people. First pathogen Campylobacter. Most of the burden is actually due to the sequelae, not to the acute phase. Then we have norovirus, I think, and then Toxoplasma gondii. This ranking is almost stable year after year. Although for Campylobacter, we are seeing a decreasing trend. We are seeing a decreasing trend. I don't know if you see here in the graph here. From 2013 and 18, we see the burden of Campylobacter going down, but you have to say that in 2018 and then confirmed 2019, it went up again. So that could be the beginning of a new trend, an increasing trend. And how also this is also added value, having this estimate done every year, so you can see that if maybe there might be a problem rising, and something has to be done. For some diseases, we don't see much of a trend. For example, rotavirus or norovirus. And for rotavirus, that's a point of discussion, because we see the burden that is going up and down every year, but it overall is pretty stable. And we have a vaccine for that. So possibly that's a discussion around that. So this number would support or not the implementation of vaccination campaign for rotavirus, for example. And these estimates are mostly used for resource allocation as well, for research funding. And in the past, Toxoplasma gondii surprised many people to have such a high burden of disease. That was one of the reasons as to why some dedicated projects were financed to find, for example, the sources of toxoplasmosis in the Netherlands. These are the costs. So for the same pathogens, you can see that for the cost of diseases, cost of illness, actually norovirus is the one accounting for most of the cost. And these are mostly costs related to other sectors, like productivity loss, for example. This is mostly because of these viral infections that mostly infect children, and parents have to take days of leave from work to attend the sick children. And yeah, so this had the huge impact in this sense. Also here you can see trends, although because also the cost of hospitalization and GP visits also rise every year, change this cost have fluctuations every year. The trends in are sometimes less informative than the ones on burden. Let me go down. We also do attribution of this burden at the level of transmission pathway, for example, food, environment, human, animal, and travel pathways. And then within the food pathway, we also attribute at the level of food group, like beef, pork, poultry, eggs, etc. This is done using expert elicitations, and which has been done a few years ago already. We use actually the same proportions. That's why for the pathogens for which we have subtyping data, now we are transitioning towards we already did actually towards a source attribution approach based on subtyping information for the strains, the isolates that we get via our surveillance system, lab surveillance system. So the advantage is that we have let's all say more robust estimate because we don't rely on expert opinions, but we can consider less sources because we don't have also isolates from all the sources we would like to have. So, for example, this is for Salmonella, done using serotype information. In this case, we can consider these sources listed here year after year. You can see here the color diffractions is the fraction attribute of cases attributed to that specific source. It's also a very nice exercise to monitor trends and to see the effect of interventions, something that you cannot do with the elicitations. For example, in this graph, it's very evident the yellow part, which is the egg-associated salmonellosis fraction, went down quite spectacularly, especially since the early 90s, when the control program in poultry in the Netherlands but Europe-wide was implemented. So we had 90% less egg-associated human salmonellosis cases in 2 decades, and overall we have a decreasing trend, but this is specifically evident for the egg-associated salmonellosis cases. Although in more recent year the situation is being changed, so this is also a very important tool to monitor trends in attribution and also the effect of your interventions, for example. As I said, because we cannot do that for all the pathogens, because we don't have the type of information for the pathogens, we still have to rely on expertization to do the attribution. So we are now working towards an integrated approach where we can combine the expert opinions with an empirical data. So the data generated from the lab surveillance, so the attribution based on microbial subtyping, for example. This is done with Bayesian evidence synthesis approach, where we actually we summarize the attributions from different studies, from different studies that can be the experimentation. It can be source attribution analysis based on subtyping information. It can also be case control studies, so epidemiological studies. It's still work in progress, but this is something that maybe I will can present next time, how we can how if we manage to do that. And this is also being done within a larger project recently this year started that is led by Tina Hald, and also Sarah Pires is involved. It's called Discover, and it's about indeed finding also new ways to do source attribution. I think I finished my presentation. Last slide. I would like to thank you, everybody. And if there is any question, I'm happy to reply.
Yeah, perfect. Thanks a lot, Lapo. So it was a great overview. Thanks for that. And the work that you've been doing in the Netherlands is indeed a great source of inspiration for any of us interested in the burden of foodborne disease. In the chat, we have a question from Caroline Schaefer. So she's asking which data you use to calculate the cost of illness.
Maybe a misexplanation of the researcher's scope.
Yeah, that's the second
do you plan to estimate the foodborne burden of non-communicable disease in the Netherlands? Okay, so the first part of the question, the cost. There are different costs. So the healthcare costs are standard and they are updated every year. We have an institute that doing that. Is the Zorgautoriteit, is like a authority supervising all the healthcare system. So GP visits, hospitalization, lab tests, these are all costs that are standard and updated every year. So we will get these estimates as such. To know which are the costs related, for example, to work time loss or travel expense, etc., We have some studies performed in the past in which for specific pathogens, but also for gastroenteritis as a whole, where we know that, for example, that a child with the giardia usually is sick for 2 days, and the parent is, on average, has to stay at home for 1 day, and that's the related cost. And so these are self-reported information from different epidemiological studies that we performed all over the years. Some of them are really, really old, like really at the beginning of the 90s. So this should be definitely updated. But we work with distributions. These are input parameters, so we put as much uncertainty and variability as we can. Second part of your question is about, yeah, this actually already been done. You can, if you go to the RIBM website, you can see that the DALIs are being calculated also for non-communicable diseases like cancer and diabetes and heart diseases. Actually, they started before us doing that, and the only thing is that they use different inputs in different methods as well. We tried. Yeah, we would really like to work the same way, not really the same way. Let's try to homogenize the approach. It's not, we haven't succeeded so far, but the DALIs per definition is comparable between diseases, so we can still compare that.
Okay, thanks, Lapo. And indeed, when doing burden of foodborne disease assessment, then you are able to integrate the impact due to the non-communicable diseases that might be the result of these foodborne infections.
So yeah, there are some issues. For example, if I may say something more about, for example, the some non-communicable diseases like I don't know, cervic cancer, which is caused by an infection like papillomavirus. Now it's calculated twice, so we have the burden of the infection itself, but also the burden of the cancer. So there are some overlaps that are pretty evident. And yeah, of course, you have the cancer is one burden, but the cause is an infection, and now it's calculated twice. So that's it's a point that we are overestimating now that, for example.
Yeah, but these infections are can be seen as risk factors for these diseases. So it's normal that you are looking at it twice. So it's looking at different dimensions of the same.
But you cannot add them up.
No.
Because then you
we have one final question from Romana. So she's saying, you mentioned that you calculated disability weights based on scientific literature. Could you elaborate on that?
Yeah, okay. So there are the weights are calculated. The standard ones provided by the Global Burden Network. I don't remember exactly, but so are the standard ones. But for some of them, I think at least in the past, I mean, it's an evolving estimation process. So we try to be comparable with previous years, but if something is a source of data, better source of data is available, then we will definitely use that. There is a publication from AXMA providing disability weights for the foodborne pathogens. And that's the one that we are using now from 2010, I think. It's not even that recent.
Lapo, maybe you can later on write the link to the publication in the chat.
I will definitely do that. Yeah. Okay. I have it.
Perfect. Right. So thanks a lot, Lapo. So then I suggest we continue with our program. And next on the program will be Binyam Desta from the University of Waterloo in Canada, who will present us some initial insights from a very exciting multi-country study in 4 African studies that aims to estimate burden of foodborne disease and also strengthen the local surveillance systems. So, Binyam, the floor is yours.
Thank you, Brecht. Hi, everyone. So I'm here, Binyam. I'm going to present the current initiative in place to estimating the burden of foodborne diseases in 4 African countries where public health impact is higher and data scarcer, as it was indicated by Sierra earlier. So in this presentation, I'm going to introduce you to the current initiative, the studies, the partners, and as well the lessons we learned so far as we are in the midst of doing the project. So to start with, different reports and as well a few studies in the literature is suggesting that public health impact of foodborne disease is higher in low and middle income countries, mainly in Africa, than was in the high-income countries, as there are lack of evidence showing the magnitude of the problem, as we don't have limited research and as well limited disease surveillance systems in these countries. And many reasons has been put forth in the literature for this that data gap, which ranges from lack of capacity, and by lack of capacity we mean lack of capacity in terms of personnel, in terms of resource constraints, for example, laboratory facilities and so on. And it ranges to lack of political commitment by the decision-making body. And also there has been a high focus only on prioritized diseases in these countries. So thus, as an initiative, we launched a multi-partnered, multi-country project named FOCAL, which you can see the logo here, in 2019. And we're working with 4 African countries, namely Ethiopia, Mozambique, Nigeria, and Tanzania. And the overall aim of this project is to estimate the burden of and as well strengthening surveillance systems for foodborne diseases in Africa. So to introduce the studies in place and as well the partners involved in the study, as I already told you, it's a multi-study project, and I'm going to focus on one envelope which includes the population survey, and that aims to estimate the incidence and distribution of diarrheal illnesses in the general population. It means the entire population of all ages in the 4 countries, and currently we are collecting data, and we're also doing a systematic literature review in order to determine or estimate the proportion of diarrheal illnesses caused by specific agents, so that we can identify the foodborne disease proportion from the diarrheal envelope. And as well, we are doing active review of available foodborne disease reporters in these countries to estimate the extent of under-reporting of foodborne diseases in the existing surveillance systems of these countries. Concerning the partners of the project, we do have 8 partners involved in this project, 1 from each study countries. Armenia University from Ethiopia, as you can see, Eduardo Mondlane University from Mozambique, Mountain Top University from Nigeria, and Kilimanjaro Clinical Research Institute from Tanzania. And also supporting partners, including Technical University of Denmark, where the PI of the project is from, and as well University of Waterloo, who is leading the population survey segment of this project, and as well partners from University of Otago, New Zealand, and from University of Pretoria, South Africa. Now we would like to share our lessons learned in doing this big project, and so in order to do so, we applied a framework developed by Larkan and colleagues published in 2016, and the framework aimed to inform collaborations in global health research. So it really helped us to reveal the lessons learned that I'm going to present now. So we have been applying leadership attributes including delegation of duties. By this we mean that partners in the study countries are playing an independent role in doing the researches, and as well they are administering their own budgets. And we also assigned a working group for our multi-studies with a lead, and as well outlining of the roles and responsibilities. And also we do have a delegation within our local study teams. We also set a milestone which really helped us to bring about the focus on a shared goal that brings the team to work towards a focused goal. So it incorporates time frame, and also it involves a description of strategies and activities that really helped us to monitor our activities in a timely manner. And we do also have regular meetings, which we conduct twice every month, bi-monthly virtual progress meetings, where we monitor our progresses and as well discuss various issues of the project, so that to enable the smooth undertaking of the project within its timeline. And we do also have a plan for annual in-person meetings, which we already have one, which is held in Ethiopia, Addis Ababa, Ethiopia, in February 2019. And we don't have any specific chain to communicate with each other or meet up. So as deemed necessary, we were meeting one-on-one or in group. Transparency is also a key attribute in our partnership, which is evident from our open communications via different channels, and as well our inclusive decision making, and also on the process we took on assigning leads for the working groups, and as well recruiting trainees in the project. And we do also have an open discussion on the benefits that came out of this project or this research, and agreed upon it. And our monitoring and reporting of achievements is also been done in a transparency way. And as we came from like multiple background and as well multiple countries, we also recognized the difference in values, for instance, in work culture difference. And we also have a sharing site where we share our working documents entirely, and the transparency also evident in our budget allocation and as well reporting of expenses. And we can also have the transparency component in the signed agreement we do have, where we enlisted the roles and responsibilities and as well the benefits that came out of this project. And at last but not least, the other attribute is that the risk mitigation plan we do have in place, which includes strategies for foreseeable challenge, which we enlisted proactively. And we do also have a binding penalty for failing to achieve milestones among ourselves. And the other wonderful experience that we like to share with you is the leading role of experts who have really an ample experience of doing similar studies in other settings, where they really helped us in designing the studies and as well foreseeing and as well reducing challenge that we could have faced, and also informing very critical decisions. This really helped us to reduce hurdles that we could have faced. And as these countries are really not well organized in doing similar studies. And experts also played a critical role in balancing the interplay between the relationship aspects of our collaboration with its operational future. That by operational future, we mean the only focus on the project delivery. So they've been playing a critical role here. And the other experience that we like to share with you also is how we adopted existing data collection tools, which has been in use in other countries. We took around a tool from around 6 countries of high income, and then we kind of adopted it to use in our diverse African population. But the process we took is really wonderful, since we contextualized. When we develop the items, we contextualize it to the local context or circumstances, and we translated the document to around 5 languages of the 4 countries, and we pre-tested the tool. So since our partners came from the countries, so they are local residents and as well speakers of the local language, we do think that this really facilitated the adoption process. And we also faced a challenge, like for instance, finding a specific terms while translating in each language, where we needed to look out for a professional who speak the particular language. So this way we try to solve this challenge. And at last, what we like to share is the approach that we put in place, the integrated knowledge translation approach, where we think would enable or ensure the uptake of our research output, as we are first using a credible study design that has been in use elsewhere, and as well our communication with or engagement of the stakeholders, since our partners already pre-identified the stakeholders, and we already invited and have the stakeholders met with us in our first project inception in-person meeting, which I stated earlier. And as well, we created a discussion platform, and we have been creating it so that our stakeholders will try to work in harmony. And the other is our monitoring plans and activities. So this all we think will ensure the uptake of our research output, and as well our study findings, which includes the future methodology for surveillance of foodborne disease, and as well experience of doing such a big research would be translatable to low and middle income countries other than our 4 study countries. So finally, I would like to acknowledge the Bill and Melinda Gates Foundation, and as well the Foreign, Commonwealth and Development Office of the United Kingdom for supporting this or for funding this project. And also I would like to acknowledge the focal team, including our gender consultant from the University of Florida, the USA. Please contact me for more information. Thank you.
Right. No, thank you, Binyam, for this very nice presentation and this initial insights in this very challenging project. So we very much look forward to seeing the results of this project appearing. I'm having a look at the chat box to see if there are any questions for Binyam at the moment. If not, then maybe a general question that I wanted to ask. Do you have a specific strategy or idea on how you would want to engage with the local policymakers, the local stakeholders, to foster their buy-in in this project?
Yeah, that's a really wonderful question. So starting from the project inception, even from the project design, we've been thinking about this. So when we, before we even launched the project, we identified the stakeholders who would really use the outcome or the output from this research. And we made an unofficial communication with them through our local stakeholders, our local partners, and we've been in touch with them. And as well, as I already mentioned in our first project inception meeting, it was held in Ethiopia, but we invited from the 4 countries, stakeholders from the 4 countries to come to Ethiopia. So we also made a platform that they could discuss and identify ways they can harmonize and work together. And in line, they would own the project too, so that they would use the outcome from this research.
Yeah. Okay. Perfect. Thanks a lot. I wish you all the best with the continuation of the project.
Thank you. Thank you.
Thanks. So then our next speaker will be Tina Halt from the National Food Institute at the Technical University of Denmark, who will present us on the use of novel methods to support burden of disease estimates. And in particular, she will show us how to make our hands dirty, literally, and to start working on burden of foodborne disease. Tina, the floor is yours.
Thank you very much, Brecht, and thank you all for inviting me to this session of this workshop. I'm going to tell you a little bit about how we, in the same project that Binyam just discussed, the focal project in these 4 African countries, are trying to use novel methodologies that we can use to support the burden of disease estimates. So obviously, what most of us working with burden of disease knows already is that we only see the tip of the iceberg from what is reported through surveillance, and that this tip of the iceberg is varying across geography, across diseases, and also therefore make it notoriously difficult to compare kind of reported cases statistics between countries. And what we really want to know is the bottom, or not the bottom really, but we want to know the whole, the size of the whole iceberg. In the focal project, we are addressing this, so trying to estimate the burden of diarrheal diseases, as Binyam also touched upon, in 3 different ways. So in the tip of the iceberg, we can get from healthcare surveillance data. So these are the lab confirmed data that are reported to surveillance. And scrolling through healthcare surveillance data in these 4 different countries might give us an idea of the burden of disease, obviously. But again, this will only be like the tip of the iceberg. Then we have the population surveys. Here we don't really have etiology on. Here we're looking at diarrheal incidences. Here we get kind of the number of people that are ill, so the burden of illness, the number of people that seeks care and have samples collected, maybe also get some data on that. So these is like questionnaires that we either ask face to face, but we also have like an online survey where virtually everybody can participate if they want to, and trying to, so it's like on a mobile app that we are collecting data. So that's the second approach to get some idea of the burden of illness. And then the third approach, which is like our novel approach, is to also get some idea of what's going on in the whole population, also including asymptomatic carriers. And here we will collect, or we are collecting data from sewage that we are analyzing for DNA content using metagenomics. I will get a little bit back to that. And then see if we, through that, can get some way of quantifying the abundance of pathogens in a population. Obviously, this will not give us a number of cases, but it might still be a useful measure for quantifying something about disease burden in a population. We obviously also like to estimate the etiology proportions, which is one thing is to find out what is the envelope of diarrheal illnesses or foodborne illnesses, but we also like to know which specific pathogens are causing it. So the etiology proportions. And here we also have like 3 approaches to try to estimate the etiology proportion. The first one is through systematic reviews. So a review of studies that has already been conducted and where we will have data from both inpatient, outpatient, and community studies, and where people participating in the studies have been examined and have been provided some kind of diagnosis, lab confirmed diagnosis, which will give us an estimate of etiology proportions. The second approach is again looking at the available healthcare surveillance data, the hospital records for those that have been reported in the surveillance system in place in the country. And then finally, we will use these metagenomic samples from sewage samples, where we hope that we can estimate quantify and then estimate the relative abundance of pathogen-specific genes in untreated sewage samples, again from the same population. And then we can, of course, compare the 3 and see, well, how they match each other. But you wouldn't necessarily think that they should actually match each other, as we're looking at a different level as a pyramid, as I showed on the previous slide. Yes, so why are we going this way? Why are we using metagenomics? Well, first of all, it's a method that detects all DNA in a sample, and DNA sequence information is really just a string of letters, and so therefore it's a universal language. And it can be provided in a standardized electronic format, and it can also easily be shared between laboratories and disciplines, and therefore also make it quite useful. And then when you first have sequenced a sample, you can archive it, and you can retrieve it again for further analysis or reanalysis if you want to. So that is also kind of neat, and all by computer. You don't have to actually go to the freezer, pick up the sample and everything. You already have the sequences in electronic format and can do all kinds of analysis on it afterwards. So very briefly about metagenomics, the metagenomics method. I'm not really an expert in this. I'm an epidemiologist and definitely not a bioinformatician, but very briefly, we are collecting these sewage samples, and we actually also in the study not only collecting sewage samples for metagenomics, we're also collecting samples from children and animals in food and environment, where a proportion of all the samples would be analyzed with metagenomics as well. But after the sewage sample has been collected, then DNA will be extracted and then will be sheared into smaller fragments, and then we'll do this library preparation, which is really just a collection of all these small fragments where there has been put some adapters on that are fitted to specific sequencing platforms. And when these paired ends with these adapters have been kind of synthesized or made, then we do quality control and we trim those parts that we think is not of sufficiently good quality. And then after the quality control, these remaining reads, DNA reads, are then mapped to known sequences. And for this, it could be we map them to pathogens, or we map them to resistant, antimicrobial resistant genes, if that's what we're looking for. So we can map it to all kinds of known reference genomes. Here it is important to mention also that before we get so far, because in a sewage sample there will obviously be DNA from many things, not only bacteria. We'll also have DNA from animals and humans, but also from viruses. So we're kind of trying to sort that out in the previous step, and then we map only to bacterial genomes and whatever genomes we're then looking for. And that will, in very simple terms, give us a table like the one presented down here. So we have like different samples, and then we can have them mapping to different levels at or different quantities to a different reference genome. So for instance, the sample one here map, what we call is a unit we call FPKM, so 23 FPKMs, which is a fragment per million reads, kilobase reads. So sample one maps 23 FPKM to reference genome 1, 15 to reference genome 2, and so on. And that would give us some kind of idea on what is in this sample. And then there are some mathematics going on here where it is normalized also to the total amount of bacterial load in the sample, and then also to what the expected gene or genome length of the reference genome is. So this is very bioinformatic heavy, but at the end of the day, this will give us some way of quantifying the amount of different reference genomes in the sample that we have. Okay, so for the focal project, our whole purpose is to find out how likely are we to, first of all, detect and quantify pathogens in sewage samples. And for this, we have set up, we have a person looking at this, and we have set up a study where we're looking into different complexities, you could say. So the green ones here are non-pathogens, and the red ugly ones are pathogens. And with different variations, so maybe we only have one species of non-pathogens and 10 different of pathogens, and then the other end we have 60 non-pathogens and 10 pathogens. And then we also look at different composition, which will mean how abundant are they, what are the prevalences. So here in this scenario here, it's 90% non-pathogen and 10% pathogens, and in a kind of a extreme situation also, like 99.99% and a very low prevalence of the pathogens here. Not going into detail, but this is then how we will try to use different mapping tools, KMA approaches to map the genomes that we have to get this quantification of well, both pathogens and not pathogens, but obviously in this study we are most interested in the pathogens. And if you look at this, some very preliminary results, in this scenario we have like 60 and 10, and we have a prevalence of 0.01 in the pathogens. And what you can see here is that in this low prevalence, the mapping tools are not extremely good at actually identifying the pathogens. Ideally, we would have had a pattern like this, but most of it is like finding E. coli and Campylobacter and so on. So in this low concentration, it seems like the sensitivity is not really good of the method. However, if we move...
Sorry, Tina, we have 1 minute. Sorry to rush you.
Okay. Have I really spoken so long already? Okay, but anyway, just to say that with this one here, it's working much better when the prevalence is 10, which is of course not a big surprise. But just to say that our next step is of course to try to increase sensitivity, test other mapping tools, and then to develop a specific pipeline for pathogen detection. And just to say also that we have made this work for surveillance of AMR resistant gene using sewage with 60 countries, collecting sewage from 60 countries all around the continents, where we have been able to quantify the sewage rhizostomes in different areas around the world. And we can see there's a huge clustering effect depending on where in the world you are, and also with high abundance of resistance in Africa and South America, and less so in Oceania and Europe. So conclusion is that sewage-based surveillance using metagenomics is flexible, scalable, and easy to implement and standardize. It's working well for antimicrobial resistance, but it still needs to be optimized in order to use it for quantifying pathogens. We believe that sewage-based surveillance can complement and support the detection and surveillance of silent epidemics or endemic diseases, clinical isolate-based surveillance, and then also support burden of illness studies. So acknowledgement, I think it's more or less the same slide as Benjamin showed, so just acknowledging our funders of the focal project and of course the focal team. So thank you very much.
Thank you very much, Tina, for an excellent presentation and an exciting eye into what the future could be on burden of disease studies for foodborne diseases. We're a bit running behind schedule, so I encourage any question on the chat function, and I would like to welcome our next speaker, Peter Souza Hoysko from the European Office of the World Health Organization. Peter, the floor is yours.
All right, thank you, Sarah, and good morning to all. So I will try and go quickly through my presentation in the interest of time, but I'll be talking about capacity building and support from international organizations. And I just wanted to show this slide to begin with, just to put it into a little bit of a broader picture and see where data and the evidence fits into broader food safety systems. So what I've put in this slide here is to show the different functions, the different stakeholders, and the enabling factors for making broader food safety systems effective and functioning at a national level. And you will see, you will see here I've circled the information underpinning the evidence as just one of the components. So when it comes to WHO and international organizations and us providing technical support to member states, we try and look at the entire systems and build systems in countries as opposed to specific components. But of course, the data, the evidence play an absolute fundamental role and the basis for risk management and for risk assessment and for policy implementation. So just to show it in a broader picture. This slide here, I think I will just skip just to show the global burden of disease that previous presenters have already introduced. So now, what can we use the burden of disease data for? And what can we use this evidence for at country level? And how do we use it in our member states and the support that we provide? So first of all, and I think we've seen that with the global estimates as well, which were the first of its kind, that they have really drawn public attention and mobilized political support at a global level, but also at national levels, subnational levels, to food safety as an important public health factor. We've used it to inform evidence-based policy development and implementation, guide resource allocation at regional level, but to some extent also at national levels, to determine prevention and control measures for food safety and to monitor the trends in terms of the effectiveness of the interventions that have been implemented at country level. How does this relate at the burden level? So from the global and regional estimates that we have already published, we're now moving to look more at providing support on conducting national studies and national burden of disease estimates. We recognize that most food safety risk assessment decisions are taken at national level or even subnational level. And for that, it's important that we also have data that shows trends at national level. The quality, the sources, the methodology used to generate country-specific data varies a lot across countries. Countries have their own approach and their own way of doing it, which makes it very difficult to compare burden of disease studies across countries. And in many of the countries that we are working in, the capacity to conduct studies is low, but I think it's equally important to acknowledge that the capacity to translate the data that may be available into action is also very low. And we only I mean, to some extent, we only produce data if we can also take action on the data. And that's where we are trying to also support our member states. So for WHO, I've tried to divide it into two. First of all, we conduct the global level burden of disease studies, and the FERG was the first of their kind that were published in 2015. We have initiated the process of developing updated estimates by 2025. Call for experts have been issued. For those of you who may be interested, the deadline for applying to be part of the expert group is on 30 October, so we still have 2 weeks. So updating the global and regional level data is ongoing. We have, not published yet, we are in very final stages of publishing a guidance document on national and subnational level burden of disease studies, the methodology for that. We have the ongoing risk assessment and scientific advice work going in the context of Codex and with our partner FAO. So that's the one part of the support we are providing, really to estimate and provide the evidence for policy action. The other part of it is to translate the evidence into action. And we do that through our global program of work, through our regional and country-specific work plans that we have for each of our WHO regions. So the forthcoming WHO guidance, and we hope this to be published later this year, is estimating the burden of foodborne diseases, a practical handbook for countries. So to how to conduct this at national level. It outlines the requirements, the enabling factors, the challenges and the opportunities for conducting national burden studies. It outlines the steps and how to derive at the estimates, and suggests some harmonization of methodology across countries. And it basically follows these 6 steps. So, and further explanation is available in the guidance document. But it really goes from the planning as the first stage, what hazards to include, what would this be used for, and so on, into the data preparation, the classification, the attribution. So what is the source attribution to the estimates that we find, and then the interpretation, and finally the dissemination of results to the ones who need it. So, and there is where the second component comes in. How do we then translate this into action? How do we use the data? How do we make sense of it? And many of our member states really need a lot of support in translating it. So some of the principles of translating data into action that we are working towards is to, first of all, to identify the long-term goals, the priorities for food safety in that particular country, or even at subnational level, if that makes sense in bigger countries. So what is the wider context? How do we consider that? And what are the trends in food safety in that particular country? How do we apply the risk-based approaches in prioritizing interventions? There may be multiple interventions possible to address a particular issue. How do we prioritize which one is the most effective in terms of disease burden, of course, but also in terms of economic cost? Establishing partnerships across sectors is very important. No one sector can do this alone, and even sometimes no one country can do it alone. So how do we also establish partnerships across national borders? And by that, keeping countries, keeping people at the center. No one solution is valid for all. So I think this is my final slide, actually. The evidence-based technical support that we provide in the WHO European region, the region that I represent, it might be different for other WHO regions, I have to say here. But we do work on antimicrobial resistance monitoring, policy development. We do a lot of work around prevention, investigation, and response to food safety and zoonotic threats using the One Health approach. And the One Health approach is something we're trying to integrate not only in the food safety zoonotic disease program, but also into other programs, neglected tropical diseases, AMR, and so on. We do a lot around food safety communications. And then, of course, we support our member states in participating in Codex, and also adopting Codex standards and guidelines into national policy and practices. So with this, I will end my slides here. Thank you very much for your attention, and happy to take any questions you may have. Over.
Thank you very much, Peter, and thank you for working on the WHO is doing to support countries in implementation studies. I'll just use 30 seconds to wrap up. Thank you all the speakers for excellent presentations. We had an excellent overview of successful examples and of well-established burden studies, novel and recent efforts to tackle burden of disease studies in other areas, and also with new methodologies and the support of the WHO and international organizations for implementation. Thanks all for the ones that attended, and again, feel free to contact us through the European Burden of Disease Network if you would like to know more, and if you're interested in support to implementing burden of disease studies of foodborne disease also. Thanks also to Brecht for co-chairing this session with me. Yeah, I think we can wrap up then.
Thanks a lot. Thanks everyone, and have a
Thanks,
nice day. See ya.
Bye-bye, thank you.